the chances of infections are very high. There is a continuous production of sputum throughout, and these require quinolones. So therefore, group A patients with only one cardinal symptom, they should not use any antibiotics. If antibiotics are indicated, then we can either use amoxicillin, tetracycline, trimethoprim sulfamethoxazole combination, or if these patients cannot take these, then alternatives are co-amoxiclav, macrolides, cephalosporins or ketolides. In group B, that is patients who are having stage 2 to stage 3 severities, beta-lactam inhibitors are used in the oral form. Alternatively, you can use fluoroquinolones like gemifloxacin, levofloxacin or moxifloxacin. And if these patients are admitted in the hospital, parenteral therapy can be given with the help of co-amoxiclav, ampicillin sulbactam combinations, or cephalosporin second or third generations, or fluoroquinolones like levofloxacin or moxifloxacin. In group C are those patients who are at risk for pseudomonas infection, and they need either ciprofloxacin or levofloxacin in high dosages. And if they are in hospital, then fluoroquinolones like ciprofloxacin, levofloxacin high dose, or beta-lactam with pseudomonas activity is usually required. So therefore, COPD forms a downward spiral when there is a slow smoldering fire of lung inflammation. If there is a continuous irritation like smoking, and there is a continuous damage to the airways, this leads to ultimately alveolar obstructions, frequent exacerbations, hypoxemia and death. So therefore, we must prevent this lung inflammation, and one of the most potent lung anti-inflammatory agent is a corticosteroid. So therefore, glucocorticoids form the mainstay in the treatment during the acute exacerbations when the patient faces these inflammatory episodes. The randomized placebo-controlled studies have shown that short course of systemic glucocorticoid therapy improves symptoms, spirometry and treatment failure rates, and shortens the length of the stay. The dose and the duration of treatment could be variable, and the high doses and prolonged treatment increases the risk of side effects. The New MS study published in New England Journal concluded that the systemic glucocorticoids improve clinical outcomes in patients who are hospitalized for exacerbations of COPD. And the 2 weeks regimen, which was compared to 8-week regimen, was equally effective. There was no need for using steroids for 8 weeks, and they have recommended therapy of methylprednisolone 125 mg 6 hourly for 72 hours. Then oral prednisolone can be substituted for the next 14 days. And the studies have shown that the initial hospitalization decreased by nearly 1.2 days with these glucocorticoid therapy. Of the side effects, hyperglycemia was the most frequent reported side effect, so therefore should be very carefully watched. Therefore, in nutshell, inhaled bronchodilators including beta-2 agonist with or without anticholinergics and oral glucocorticoids are the effective treatment for the exacerbations of the COPD. This has been accepted by the gold as an evidence A. Now, often these patients would be admitted with the decreased partial pressure of oxygen in their blood, and therefore would need supplemental oxygen. What are the mechanisms which are responsible for this hypoxemia? There is a ventilation perfusion mismatch. There could be shunt either due to the pneumonia, or whether the exacerbation is due to pneumothorax, or they may be having associated heart failure, or they could be hypoventilating. And goal is to increase the oxygen in the blood either by a low flow system, that is 1 to 2 liters per minute, or high flow system using 24 to 28% venturi, so that we achieve a 90 to 92% saturation or a PaO2 of 60 to 65 millimeters of mercury. PaCO2, if it rises, it can be accepted up to 60 or to 65 millimeters only. Therefore, supplemental oxygen therapy is often required in acute exacerbations and always in patients requiring hospitalization. We should always watch for development or aggravation of hypercapnic respiratory failure. Patients with an altered gas exchange are at the greatest risk for this respiratory failure. And why we need oxygen is basically because it relieves pulmonary vasoconstriction, right heart strain, it lessens the myocardial ischemia, it improves the cardiac output and oxygen delivery to the CNS and other critical organs. Often we have noticed in our emergency department that the doctors put oxygen to the COPD patients and go away. Oxygen is a double-edged sword. It has to be monitored very closely. As I suggested, that oxygen needs to be given only to raise the PO2 only to up to 60 to 65 and saturation of 90 to 92%. If hypercapnia occurs, this is due to reduced ventilator drive. COPD patients are actually having a hypoxemic drive. They having hypercarbia, and hypercarbic drive is gradually become low and low, so they are basically surviving on the hypoxemic drive. And when we give oxygen, this ventilator drive is removed, and so this leads to reduced ventilator drive and they go into hypoventilation. There is a Haldane effect, there is a ventilation perfusion mismatch, and there is an increased physiological dead space. There is a increase in when we give oxygen, then the reflex vasoconstriction which occurs in the lung, it goes away, and this leads to perfusion of the areas which are not really ventilated, and this leads to ventilation perfusion mismatch and increase the hypoxemia and increase the carbon dioxide content of the blood. What is the role of non-invasive mechanical ventilation? This non-invasive ventilation will be discussed in details in the next lecture. However, it is a proven adjunct for the severe acute exacerbation. It reduces the need for endotracheal intubation, decreases complications, shortens the hospital stay, and reduces the hospital mortality rate. Non-invasive ventilation is provided with the help of either a nasal mask or an oral nasal mask, and this actually is to assist the patient in his ventilation. But it requires a close monitoring. Patients who are having excess secretion or patients who are prone for vomiting cannot be provided with this, or patients who are having altered mental state may not be able to tolerate this non-invasive ventilation. A close monitoring is always required, and we need to post somebody who can actually watch closely. A patient whose drive is very low or patient who can go into apnea cannot be provided with non-invasive mechanical ventilation. Lack of improvement in respiratory acidosis and respiratory rate in the first few hours means that there is not likely to be helpful, and therefore it should not be continued. A confused, non-cooperative patient or patient with large secretions are less likely to respond, so they should not be offered a non-invasive ventilation. Non-invasive ventilation, if it is not given, then the patient may need an invasive ventilation, that means endotracheal intubation and connecting with the ventilator. The indication for this would be either failure with the non-invasive ventilation, or patient is not tolerating this, or there is a multi-system failure, or patient is hemodynamically unstable, or there is a decreased level of consciousness. Last three, that is multi-organ failure, hemodynamic instability and decreased level of consciousness, would make it as a choice. What are the indications for invasive mechanical ventilation in COPD patient with an acute exacerbation? Now, patients having severe dyspnea with the use of accessory muscles and paradoxical abdominal motion. If the respiratory frequency is more than 35 breaths per minute, if there is a life-threatening hypoxemia, that is, the oxygen is very low, less than 40, or PaO2 by FiO2 ratio is less than 200, then the patient should ideally be put on invasive mechanical ventilation. If there is a severe acidosis, if the pH is below 7.25, or if the CO2 levels are more than 60 and they are actually in fact rising, then it suggests that we must undertake invasive mechanical ventilation. If there is a respiratory arrest, which is quite obvious, if the patient is having somnolence or impaired mental status, which may indicate either there is a severe rise of the severe rise in the CO2, or if there is a damage to the brain due to either hypoxemia, then these patients should be mechanically ventilated. If there is a cardiovascular complications like hypertension, shock or heart failure, or there are other complications like metabolic abnormalities, or there is a sepsis, or the patient is having pneumonia, or we suspect pulmonary embolism, if there is a barotraumas or there is a massive pleural effusion. And lastly, non-positive pressure that is NPPV failure, or there is a contraindication for the use of the non-invasive devices. Now, which patient should be admitted to the hospital and which patient should be transferred to the ICU? Hospitalization criteria are: there is a marked increase in intensity of symptom. The patient now cannot be treated at home. Therefore, he is ideally treated at hospital. If there is a severe background COPD, or there is a significant comorbidities, or there is an onset of new physical signs such as cyanosis or peripheral edema, if there is a failure or exacerbations to respond to initial medical management, and there is a newly occurring arrhythmias, there is a diagnostic uncertainty, or the patient is very old, or there is insufficient home support. Indication for hospitalization and ICU admission. Now, ICU admissions: patients who are having severe dyspnea that do not respond adequately to initial therapy, even in the hospital they should be moved to the ICU. Patient who is confused, having lethargy, coma, or there is a persistent or worsening hypoxemia, or there is a hypercapnia or respiratory acidosis when it is occurring despite supplemental oxygen and non-invasive ventilator support, then these patients should ideally be shifted to ICU and managed intensively. And discharge criteria: patients who have been now treated, when they should be discharged. When the inhaled beta-2 agonist therapy is required no more frequently than every 4 hours, then the patient is now on a maintenance therapy of 6 hours, these patients are now fit to be discharged. Patient is able to walk across the room if he was previously ambulatory. Patient is able to eat, sleep without frequent awakening by the dyspnea. Patient has been clinically stable for about 12 to 24 hours. Arterial blood gases have also been stable for 12 to 24 hours. Patient or home caregiver fully understands the correct use of the medication. The patient now can be treated easily at home, and there is a follow-up and home care arrangements have also been completed. Patient, family and physician, when they are confident, then patient can be managed successfully, now can be discharged. And the last few slides: the ideally to prevent exacerbation, prevention is always better. One goal of therapy for COPD therefore is to prevent these debilitating exacerbations, since doing so will have important health benefits. Smoking cessation is the most important. Vaccination has now proven against influenza and pneumonia to prevent the exacerbations frequently. Regular use of inhaled steroid in patients with severe underlying COPD. Often patients leave their inhalers and then land up with the acute exacerbations. Regular use of long-acting beta agonist or anticholinergic inhalers, as has been outlined earlier by Dr. Bhattacharya. Pulmonary rehabilitation program and patient education for an early recognition of COPD exacerbation symptoms. Thank you.
Thank you so much, Dr. N.K. Gupta, for telling us about the management of acute exacerbation of COPD. That was all about this particular session. But before telling you about the next session, I have one special information for the CME workshops for DNB students and consultants, and that is that in order to sensitize the DNB students and consultants, some CME programs would be organized, and these programs are CME programs in preparing for theory examinations, for practical examinations, for research thesis research methods, and in clinical and surgical skills for DNB students in surgery, OBG, orthopedics and anesthesia only, and CME workshops for consultants on bedside teaching, research methods and evaluation. The concerned students and consultants are required to apply for these CME programs immediately on the registration format on the website, along with the registration fee by 28 February 2009. And if you want to know about the centers for these CME programs, the centers would be in New Delhi, Chennai, Hyderabad, Bangalore, Kolkata, Calicut and Pune. And the topic of our next week's teleconferencing program would be radio diagnosis and neurosurgery, and this program will be held on 12th February 2009. In our next session, Dr. J.C. Suri would be with us, who will tell us about the strategies in mechanical ventilation and non-invasive ventilation in COPD patients. Till then, keep watching your own channel, your own program, teleconferencing program.